Hello and welcome to our program, Building Resilient Care Communities for Relapse Refractory CLL, Collaborative Sequential Approaches in an Era of Innovative Options. I'm Megan Thompson from Memorial Sloan Kettering Cancer Center. I want to introduce tonight's panels. Dr. Krish Patel is joining me. Hello, Dr. Patel.
Hi, thank you, Dr. Thompson. It's a pleasure to be here.
And I'm also joined by Dr. Spencer Bachow. Welcome, Dr. Bachow.
Thank you, Dr. Thompson. I'm looking forward to discussing a few cases with you and Dr. Patel a little bit later today. I think it's going to be an exciting and educational program today.
Thank you to PeerView and the CLL Society for providing this session and Lily for providing the educational grant for this symposium. As a reminder, please look out for additional polling during the presentation. And you could submit your questions via the live chat function, and we'll answer them throughout the event. You can visit us at peerview.com/2024CLL and view the slides as well as practice aids now and then download them after the event. So to kick things off, we're going to talk today about targeted agents, which are really the standard of care in chronic lymphocytic leukemia in 2024, and also a newly approved cellular therapy option. The first covalent BTK inhibitor approval was in 2013, and since that time, multiple BTK inhibitor options have been approved. You see on this graphic the covalent BTK inhibitors, ibrutinib, acalabrutinib, and zanubrutinib. BCL2 inhibitors are also a tool in the toolbox for CLL with venetoclax. And we now have a non-covalent BTK inhibitor approved, pirtobrutinib. And we'll talk a little bit today about the recent approval of CD19-directed CAR T-cell therapy for CLL with liso-cel. How these newer modalities are used in sequence is an area of ongoing interest for clinicians, and there's a lot of research going on in this space to inform our clinical practice. As covalent BTK inhibitors have been approved in CLL, there has been some data to look at treatment patterns over time. This is an analysis of records from the Medicare Advantage Health Plan database, looking at patients with chronic lymphocytic leukemia treated from 2014 to 2021. And you do see sequencing data here looking at patients who are treated with BTK inhibitors. And we see patients do sequence sometimes within the BTK inhibitor class, as well as patients sequencing to alternative therapy, including BCL2 inhibitors. Now, we will highlight that in this data, we don't know the reason for discontinuation of the first BTK inhibitor, but I think this data brings up a really good discussion point that we'll address during the program, which looks at if patients receive a BTK inhibitor first and then discontinue for intolerance, it is an option to switch to an alternative covalent BTK inhibitor if the toxicity was a manageable one. And we'll talk a little bit more about that in the presentation. Although if a patient discontinues a covalent BTK inhibitor for progression of disease, typically we do not recommend going to another covalent inhibitor, but rather switching to another class of therapy. This data highlights an unmet need for patients with double refractory or double exposed CLL. So this is a retrospective study of patients with CLL who received both a covalent BTK inhibitor and venetoclax. So exposure to both being double exposed, and then patients who were really refractory or progressed on these agents being double refractory. You can see that there is a difference between patients who are exposed and may have discontinued the prior therapy for a reason other than progression versus those who are refractory. The outcomes are really quite poor with not very many durable responses in the double refractory patient population. So this data really is one study that highlights that more effective options are needed for patients previously treated with a covalent BTK inhibitor and venetoclax. We do have new tools, pirtobrutinib, non-covalent BTK inhibitors, as well as CAR T-cell therapy that we'll address for this population later in the program. This is a poll from a survey of community-based hematologist oncologists in the United States taken in September of 2024. And this is looking at a patient with high-risk CLL who was treated with a covalent BTK inhibitor for first-line therapy, but then had progression of disease during treatment with the BTK inhibitor. Genetic testing shows TP53 mutation and complex karyotype, and this was confirmed at the time of progression. And respondents were asked to select the next steps. And you can see here that there's heterogeneity in terms of how clinicians are currently using genetic testing to inform treatment results and what testing's being done at the point of progression again. We see that it's kind of split evenly throughout oncologists and the answer options here. Some of that might have to do with the availability of testing. I will highlight here that IGHV mutational status does not need to be repeated with each line of therapy because that shouldn't change over time. But things such as TP53 mutational status, as well as cytogenetic testing, should be repeated at the time of progression, as that can be change over time. And then this is data from CLL patients taken from a CLL Society webinar. And this shows about topics of interest that CLL patients have. And I think really relevant for some of the topics that we're going to discuss today is patients are very interested in sequential treatment and longer term care in addition to clinicians, given the emerging amount of patients who've had exposure to targeted agents. So the other key topic, and we'll touch on some of this today, is also safety of agents, so side effects, as well as supportive care measures for CLL patients. So with that, let's get into our goals for today. We're going to enhance your knowledge of evidence and guideline updates supporting the sequential use of non-covalent BTK inhibitors and CAR T-cell therapy. We'll provide guidance for capturing prognostic factors, relevant mutations, and other factors that can inform sequential treatment planning in CLL. Equip you with the skills you need to develop personalized sequential treatment plans for patients with CLL, and help you to provide team-based strategies for practical therapy delivery considerations during the management of relapsed CLL. I want to thank our partners, the CLL Society. You can visit cllsociety.org. There's a lot of resources for both patients and providers on the CLL Society. Here are some of the resources available on the website at a glance. These are excellent resources for patients as well as care teams to check out. So with that, we'll go into our program and we're going to review key evidence and guidelines with BTK inhibitors and CAR T-cell therapies. BTK inhibitors and BCL2 inhibitors are really the backbone of clinical practice for patients with CLL in 2024. Here you're seeing the NCCN guidelines, and you can see that for first-line therapy, really the preferred treatment options are BTK inhibitors or venetoclax-based therapy. BTK inhibitor options are also recommended in the second and third line settings, dependent on the prior therapies that the patients have received. So again, acalabrutinib and zanubrutinib as monotherapies with a treat to progression strategy are recommended. These have been shown in the relapse setting to have, in separate randomized trials against ibrutinib, fewer toxicities with at least equivalent efficacy and a progression-free survival benefit compared to ibrutinib for zanubrutinib in the case of the Alpine study. And then in terms of preferred regimens, venetoclax is also an option, either as monotherapy or in combination with an anti-CD20 antibody. Here are current guidelines looking at relapse refractory patients and focusing in on those patients who have received both a covalent BTK inhibitor and venetoclax. So now we have more tools in the toolbox for treatment of CLL. Pirtobrutinib is now FDA approved in this setting. and excellent options for patients who have received both venetoclax as well as a covalent BTK inhibitor, including that double refractory patient population. And more recently, liso-cel, which is a CD19-directed CAR T-cell therapy, is also FDA approved in this setting for eligible patients. And these are the two treatment modalities that we'll focus on today and delve into the data for these approaches. So this slide is just to highlight, it's really important to do prognostic testing for your patients with CLL, SLL. I want to highlight just a couple that are important in terms of risk in the area of targeted agents. So FISH testing should be repeated prior to first treatment and then at the time of each relapse, as the CLL can undergo cytogenetic evolution. Deletion 17p, which is deletion of the p53 gene by FISH, is important to tease out, as that is a high-risk prognostic feature. In addition, DNA sequencing for a p53 mutation, which can present concurrently with a deletion on the other allele, it's actually the most common situation, about 2/3 of patients have both, should also be performed. IGHV mutational status should be performed during a patient's diagnosis with CLL, but doesn't actually change throughout the disease course, so does not need to be repeated with each line of therapy. And then karyotype analysis, so a CPG stimulated karyotype analysis of the CLL should also be repeated, as we know that complex karyotype, at least three or more cytogenetic abnormalities has been associated with less favorable outcomes and is an important prognostic factor. And this has been shown with BTK inhibitors, for example, ibrutinib. So toxicity and progression are both issues that have led to the discontinuation of BTK inhibitors. So on the left, you see data about ibrutinib. So this is data pulled from 4 prospective studies, and you can see that patients discontinued BTK inhibitors for both progression, but also other events. And toxicity was traditionally a major problem leading to discontinuation for CLL patients treated with ibrutinib. This is also seen on the right. You see data for discontinuation for acalabrutinib and ibrutinib, and you see adverse events as well as disease progression are reasons for discontinuation. We now know more about why patients stop responding to BTK inhibitors. In the case of ibrutinib, mutations in the cysteine 481S position on the BTK binding site really are the dominant resistance mutations, and there's more and more data coming out for acalabrutinib and zanubrutinib where these mutations have also been observed. Really, this particular mutation prevents the covalent inhibitor from binding effectively to the target. There's some other mutations you can see here. This shows not just the B cell receptor signaling pathway, but hones in on the BTK protein. And you can see a big heterogeneity in terms of different mutations that are emerging with the host of different covalent and non-covalent BTK inhibitors, mostly at the tyrosine kinase catalytic domain of the BTK protein. I think the take-home message here is that we're learning more and more about BTK inhibitor resistance testing. It's not currently the standard of care to need to perform on every patient, because clinical progression should really still drive our treatment decision-making at this time point. But it might have clinical applications in the future and provide additional information. And as we learn more and more, this could have help inform sequencing. But right now, clinical progression is really still the reason to change therapy. And these resistance mutational testing can be supportive information as we care for patients. So non-covalent BTK inhibitors were designed to address the limitations of covalent inhibitors, including resistance and intolerance that were traditionally seen. And as well as we talked about earlier, this double exposed and double refractory patient population, so patients requiring treatment after a covalent BTK inhibitor and venetoclax. And it's now been shown, and we'll review the data, that non-covalent BTK inhibitors can overcome resistance to covalent inhibitors. These drugs bind reversibly to BTK. This is in contrast to the covalent inhibitors that bind irreversibly. Pirtobrutinib is now FDA approved in this setting. This is a highly selective non-covalent BTK inhibitor that has really minimal off-target effect against non-BTK kinases. And nemtabrutinib is a non-covalent BTK inhibitor that's currently in clinical development and clinical trials. So let's learn more about covalent and non-covalent BTK inhibitors, how they work. And this is a short video that delves into their mechanism of action and also can help provide insight into resistance mechanisms.
Let's take a closer look at this specific enzyme, BTK, and its role in B-cell malignancies. In malignant B cells, BTK can become overexpressed. With overexpression, it becomes persistently activated, initiating a signal cascade. This leads to proliferation of the malignant cell, allowing it to thrive, resulting in patients having disease progression. Covalent BTK inhibitors, such as ibrutinib, acalabrutinib, and zanubrutinib, are dependent on binding the BTK site at a specific location in an irreversible fashion, resulting in inhibition of BTK activation. These drugs are incredibly effective for patients with B-cell malignancies, but unfortunately, resistance can occur. The most common resistance pathway identified is a mutation specifically at the C481 site, which makes it difficult for covalent BTK inhibitors to bind. This is the most common mechanism for covalent BTKI resistance in CLL and affects all agents in this class. Decreased binding efficiency results in resistance, which allows for increased BTK enzymatic activity, and ultimately for patients, disease progression. A new class of drugs called non-covalent BTK inhibitors has been shown to be effective even in patients who have disease progression and known resistance mutations after a covalent BTK inhibitor. One such agent is called pirtobrutinib, which is now FDA approved in relapsed refractory mantle cell lymphoma and CLL after at least 2 prior lines of therapy. This drug blocks the ATP binding site of BTK in a reversible, non-covalent fashion, which represents a different mechanism of action, and by doing so is able to overcome the resistance mutations that have occurred in patients who have progressed on a covalent BTK inhibitor.
So now we're going to move on to talk about the data for non-covalent BTK inhibitors. Before that, though, I'd like to pause, and if you could take a moment to answer the polling question about BTK inhibitor resistance, please do that now, and then we'll talk more about pirtobrutinib. So the Bruin study demonstrated pirtobrutinib was efficacious and safe in relapsed refractory CLL patients. So this is data from the CLL cohort. All of these patients presented had prior BTK inhibitor exposure, so 247 patients. And you can see here from the waterfall plot that patients who discontinued the prior BTK inhibitor for either progression or toxicity had excellent responses. The overall response rate was 82% in the overall population, and then in the double exposed patient population, which was 100 patients, 79%. Most of these responses were partial responses, and pirtobrutinib, the approved dose, which was the recommended phase 2 dose in this study of 200 milligrams, also showed durable efficacy, and we'll take a look at that data. So this is looking again in subgroup analysis, and you can see that really including in high-risk patients, so patients with deletion 17p or a p53 mutation, you can see a high overall response rate, both without and with TP53 aberrancy. And the other subgroup that is interesting to look at is that pirtobrutinib also showed excellent overall response rate in patients who did have prior BTK cysteine 481 mutations or the mechanism of resistance to covalent BTK inhibitors. This is progression-free survival data in the overall previously BTK inhibitor exposed pretreated patients. So median progression-free survival of 19.6 months at a median follow-up of about 19 months. So we do see durable responses in this patient population. And this, compared to historical retrospective controls for this patient subgroup, is quite durable. And then you also see at longer follow-up here, you'll see regardless of whether patients receive prior BCL2 inhibitors, we see durable responses. So in patients who were BCL2 inhibitor naive, median progression-free survival of 23 months. And then in patients who were exposed to a BCL2 inhibitor, and again, all of these patients also received a prior BTK inhibitor, the median progression-free survival was 15.9 months. And then this is data to suggest that another option for double exposed patients could be venetoclax retreatment. And so we see many patients discontinue venetoclax for reasons other than disease progression, particularly when venetoclax is used as a fixed duration therapy. So you'll see here data for venetoclax retreatment. These are patients who receive venetoclax in any line of therapy and then were retreated with venetoclax in a subsequent line of therapy. Overall response rate of about 80%, including just over 50% of patients with prior BTK inhibitor exposure, so some double exposed patients here, and a median progression-free survival of 25 months. And there are ongoing prospective studies to validate retreatment further. So now I'm going to hand it over to Dr. Patel to talk about next steps with non-covalent BTK inhibitors and also cellular therapy.
So as Dr. Thompson alluded to, we are starting to generate more and more data with non-covalent BTK inhibitors. First, obviously, has been with monotherapy, and now starting to look at combinations of non-covalent BTK inhibitors with therapies like venetoclax and or CD20 antibodies. And so here is shown data from an early phase trial, part of the Bruin trial, where there was a cohort of patients who received venetoclax with pirtobrutinib, and then a cohort of patients who received the combination with rituximab as well. And what we can see from this small study is a very high overall response rate and a very high undetectable or unmeasurable measurable residual disease rate, really suggesting that we can, again, hopefully look to develop combinations of therapy with the goal of having time-limited therapy. And importantly, when we combine these therapies, no dose-limiting toxicities were seen. There are some adverse events that we have to pay attention to, like neutropenia and other cytopenias, but encouraging data nonetheless. And as was alluded to previously, there are now larger phase studies like the Bruin CLL 322 trial looking at the combination of a non-covalent BTK inhibitor, pirtobrutinib, with venetoclax. What about other non-covalent BTK inhibitors? So nemtabrutinib, which is a reversible BTK inhibitor, is also being studied in patients with B-cell malignancies, including CLL. Here we present some results from the BellWave 001 trial. This is a study of patients with CLL, SLL, treated with nemtabrutinib at a fixed dose once daily. And these patients, as you can see here, were divided into two cohorts: those patients who had presence of a cysteine 481S mutation, which is typically associated with resistance to covalent BTK inhibitors, and those patients who did not have the presence of a C481S mutation. And in both groups of patients, we see, again, a very good activity and overall response rate in all comers of 56%. And looking at progression-free survival, we can see, again, the durability of disease control for those patients in the cohort with C481S mutations. For the median follow-up that's been presented thus far, the median progression-free survival for this cohort is 15.7 months. So we await more data from studies like these to ultimately inform us of what other therapy options may become available in the setting of particularly double exposed patients. As Dr. Thompson highlighted, we also have cellular therapy available for patients with CLL, in particular the use of lisocabtagene maraleucel, which is a CD19-directed CAR T cell with a 4-1BB co-stimulatory domain. The approval of liso-cel is based on the Transcend CLL-004 study. So in this study, patients who had previously either had progression on a BTK inhibitor or were not eligible for a BTK inhibitor and who had varied other therapies for high-risk patients, at least 2 prior therapies, for standard risk patients, at least 3, were enrolled on the study, underwent leukapheresis and manufacture of autologous CAR T cell, and then subsequently lymphodepletion as shown here, and a single CAR T cell reinfusion. So this is a study that's presented several different data cuts, but here we're looking at a very specific cohort of patients enrolled in the study. These are patients who had prior progression on a BTK inhibitor and also progression on venetoclax, so that double refractory population, 49 patients in total. And what we saw in this cohort is that the overall response rate, so the patients that had complete responses or partial responses, made up around about 42% of patients. Now, importantly, these are patients that were heavily pretreated, including many that had had prior chemoimmunotherapy, had both classes of targeted agents that I mentioned, and potentially in some cases, other therapies as well. So these were patients that were very heavily pretreated and typically challenging to treat. So I think that context is important. Importantly, we see for the patients who achieved a complete response, which was about 18.4% of the patients, those patients had a very, very impressive progression-free survival as represented in the blue curve and the Kaplan-Meier over here. When we look at patients with partial responses, they also had a good progression-free survival in the context of what I shared, that very late-line setting, 26.2 months. And so importantly, we now have FDA approval for liso-cel for patients with relapsed refractory CLL who have had at least 2 prior lines of therapy, including a BTK inhibitor and a BCL2 inhibitor. So next, we'll shift gears a little bit and talk about how do we safely collaborate in the care of patients receiving therapies like CAR T cells, and what is really needed to be managed in patients who are undergoing therapies for CLL, especially in later lines. So the first is to really highlight that there are many important phases in the care of a patient with CLL, and this really does become a collaborative team to help manage the patient's needs and to really get the best use out of each therapy we have and to manage toxicity as best we can. So this is often going to look somewhat like this. Patients may have community oncologists that then periodically are going to be supported by maybe a CLL specialist in an academic setting. But there are so many other people who are important in this role as well. Oncology nurses who can help educate patients about adverse event management, pharmacists who help us to be aware of things like drug interactions, and as Dr. Thompson highlighted, importantly, pathologists who help us at each point in time where we might be making a change in the decision of how to treat the CLL, provide important information that ultimately helps guide that therapy. So thinking about some of those newer therapies, non-covalent BTK inhibitors, we'll start there and say, like any other therapy, we have to be really mindful of potential drug interactions. Pirtobrutinib is given 200 milligrams once daily. It does have some interactions with the CYP3/4A pathway. So for patients who are on strong inhibitors, we may want to avoid use of that strong inhibitor if possible. And if it's not possible, then reduce the dose of pirtobrutinib by 50 milligrams. For those patients who are taking medications that are moderate or strong CYP3A inducers, again, we may want to try to avoid use if possible, but if not possible, adjust the dose of pirtobrutinib to 300 milligrams daily. Fortunately for pirtobrutinib, no dose adjustment or change is needed in patients who are receiving gastric acid-reducing agents. And as with any other BTK inhibitor, there are some class-specific adverse events that we want to pay attention to, in particular, infections, bleeding risk, cytopenias, rare cardiac arrhythmias, and secondary primary malignancies. These are all things that we want to educate our patients on and make sure that if these events are occurring, that we are actively assessing those and helping to manage those. To speak to what we see with pirtobrutinib in some of these class-specific BTK-mediated adverse events, we have a lot of data generated from the Bruin trial, over 282 patients now treated with CLL/SLL. And fortunately, what we see is that overall treatment-related adverse events are quite low, both of an any grade nature as well as a high-grade nature. Particularly, I'll share for the follow-up that we have to this point, fortunately, hemorrhage and high-grade bleeding events are quite rare. Hypertension also seems to be at least treatment-related hypertension generally low, and similarly for atrial fibrillation as well. And we know that when patients are on these therapies for a prolonged period of time, that we need to continue to follow that safety data long-term to really understand what that risk looks like over time, but very good safety data to date with pirtobrutinib from the Bruin trial. Now, thinking a little bit more about cellular therapy, here, cellular therapy, in particular CAR T-cell therapy, does present some unique toxicity risks of its own. Primarily, we think about the short-term acute toxicities being cytokine release syndrome and neurologic toxicity. These are typically toxicities that are going to be managed in the center delivering the cellular therapy. And what we see in patients with CLL and SLL treated with liso-cel in the Transcend 004 trial is that all-grade CRS was fairly common, as you see in the table here, occurring in about 85% of patients. But most of the CRS was typically considered low grade, grade 1 or grade 2, with just under 10% of patients having higher grade CRS. Now, we have very specific tools to manage cytokine release syndrome, including tocilizumab and corticosteroids, and up to 2/3 of the patients on the study did receive either of those two therapies to manage cytokine release syndrome. For neurologic toxicity, we saw that just under half of all patients had some form of neurologic toxicity. But again, fortunately, this was mostly low grade. There was a signal for some high grade neurologic toxicity, grade 3, about 18% or so. But again, these toxicities tend to be reversible and are managed with the use of medications like corticosteroids, which are a mainstay of neurologic toxicity management. What are some other things that we should consider in the delivery of CAR T-cell therapy for patients with CLL? Well, I think the first point is a really important one, is to recognize that in the process of delivering CAR T-cell therapy, this is not an instant off-the-shelf type therapy. It takes time to coordinate the care that's needed. It takes time to manufacture the CAR T-cell for the patient. And so often we really want to be thinking about this upstream of when we need it. So what do I mean by that? When patients who are progressing with, say, second or starting third-line therapy for CLL, that's a really good time to think about where do I envision the role of CAR T-cell therapy for a patient. If that is not a therapy that I deliver in my setting, can I connect them with a cellular therapy specialist that can evaluate them and help us to really try to prepare for that need, depending on when and what the patient's preferences are, and what the CLL itself will kind of dictate. CAR T-cell therapy, like other cellular therapy, can occasionally be associated with infusion reactions, so it's not unusual for us to use antipyretics or antihistamines on the day of infusion. And as I mentioned previously, for patients who develop CRS, we want to have tocilizumab available and to treat that unique toxicity to CAR T-cell therapy. And for this reason, CAR T-cells are given in certified healthcare facilities only. Things that are less common in the short term, but perhaps equally important, if not more important in the long term, are really to think about cytopenias and immune suppression. We know that that is a substantial adverse event associated with CAR T-cells. and we want to really think about a plan to try to minimize the impact of the immune suppression, or at least minimize the risk of infections in our patients. So it's quite common for patients to be on prophylactic medications, occasionally need periodic intravenous immunoglobulin to manage hypogammaglobulinemia, and also maintain a relationship with the CAR T cell treating center to observe and manage these more medium to late term toxicities that are seen. So to conclude, we're going to bring this all together in an animation to really outline how we think about sequencing therapy in CLL. But before we do that, I'd like to ask you to take a few minutes to answer some of the polling questions here. So when we think about first-line therapy, as Dr. Thompson nicely highlighted for us, we really have two mainstays of therapy. One is a continuous BTK inhibitor treatment to progression model. The other is the use of fixed duration venetoclax and obinutuzumab. So if patients have started with a covalent BTK inhibitor, a natural consideration for second-line therapy would be to switch classes and use a venetoclax-based therapy, often with an anti-CD20 antibody. You can use single-agent venetoclax if there are specific reasons one is hoping to avoid an anti-CD20 antibody. And there is some consideration to using non-covalent BTK inhibitors in this setting, but this is an area where we'll look to see more data generated from some of the ongoing trials that were previously mentioned. For a patient who started with fixed duration venetoclax and obinutuzumab, we have really two primary considerations. One is to switch to the model of continuous BTK inhibitor with a covalent BTK inhibitor, or depending on the duration of the remission patients had and how well they tolerated venetoclax-based therapy, we could consider retreatment with venetoclax, and there's data to support that. For patients who are then needing a third therapy or beyond, here we start to think a little bit about the duration of remission that the patient has had after their last line of therapy. Our two main tools here for patients that have already had a covalent BTK inhibitor and have been exposed to venetoclax are going to be consideration of a non-covalent BTK inhibitor or CAR T-cell therapy. In a lot of instances, these two therapies may be used in tandem. It's not unusual for us to potentially use pirtobrutinib as a bridge to CAR T-cells in patients where that may be the ultimate therapy choice. And then for some patients, that may be continuous non-covalent BTK inhibitor therapy. For patients perhaps who had had a venetoclax-based therapy and had had a prolonged remission to it, we could consider retreating with venetoclax as well. And so we see here a couple different considerations, but largely considerations for non-covalent BTK inhibitor or CAR T-cell therapy. And for patients who are intolerant, we think about intolerance potentially to ibrutinib. This may be in patients who are treated with ibrutinib for a long time, potentially depending on the intolerance and experience, we might be able to switch to a more selective second-generation covalent BTK inhibitor, or potentially sequence to pirtobrutinib or venetoclax. And for those patients who are already on the second-generation BTK inhibitor, similar consideration. As long as these patients aren't progressing, we can consider an alternative covalent BTK inhibitor, or alternatively pirtobrutinib or venetoclax.
Thank you so much, Dr. Patel, for that overview. Now we're going to delve into some patient cases, and I'm going to invite our colleague, Dr. Bachow, to join here, and we'll talk about how to apply some of this data that we heard about in the first portion of the presentation. So the first case is a patient with CLL who's progressing on second-line therapy with a BTK inhibitor. So Amanda is 75 years old. She has relapsed CLL, deletion 17p, and unmutated IGHV status. She was initially treated with fixed duration venetoclax and obinutuzumab and had a 2-year remission after completion of the 1 year of therapy. At that time relapsed and then was treated with a covalent BTK inhibitor, acalabrutinib, as second-line therapy, had a durable response for 3 years, but is now showing signs of progression on second-line acalabrutinib. So some points for discussion in terms of progression on a covalent BTK inhibitor. Is resistance mutation testing necessary? And what are kind of the next steps for this patient? And I'm going to invite my colleague, Dr. Bachow, to kind of comment on his thoughts of how he would approach this case.
Thank you, Dr. Thompson. Here's what I think about after seeing a patient like this. As far as testing for resistance mutations, I would like to do that to document that there actually is resistance to a covalent BTK inhibitor, although it probably would not change my management. What I would likely do is switch this patient to a non-covalent BTK inhibitor, pirtobrutinib, which is the only one that I'm aware of that's FDA approved right now. On a patient like this, I would at least have a discussion about a referral for an appointment to discuss CAR T cell therapy with a doctor that actually administers CAR T cell therapy. The other option as well is that if the patient really had a 2-year remission on this venetoclax-based therapy front line, since he did have somewhat of a prolonged, he or she had a prolonged remission, I could consider retreating this patient with venetoclax-based therapy.
Thank you so much, Dr. Bachow, for that really detailed explanation. Dr. Patel, do you have any additional thoughts on how you approach this case and, in your clinical practice, some of the considerations you have in this setting?
No, I thank you, Dr. Bachow. I think he's summarized it really nicely, and it really aligns with my approach. I think probably the only thing I would emphasize as a point you raised is really when we start a new therapy, thinking about, is this patient potentially going to benefit from CAR T cell therapy as early as possible, and really making that connection helps us to kind of maximize our options.
Thanks so much, Dr. Patel. I totally agree. I think that this is a great example of treatment planning in partnership between oncologists, a situation that we come up, especially if you know that you have a patient who might potentially benefit from cellular therapy, starting that planning process early on. So we're going to continue on in our case. We're going to think about non-covalent BTK inhibitor therapy and specifically thinking about starting pirtobrutinib. So Dr. Bachow, I'm going to have you comment on how are you counseling patients about starting pirtobrutinib, this being one of the more recently approved drugs for CLL? What are the considerations for dosing and safety? And, really, how does your counseling change when considering other treatment modalities also outside of BTK inhibitors?
Sure. So the way I would present it to the patient is I break them into several different categories. One would be, which is probably what I would probably not do or not be my initial preference, would be repeating venetoclax-based therapy. I would tell the patient they somewhat know what to expect because they already have been on venetoclax-based therapies previously. With regards to the non-covalent BTK inhibitor, pirtobrutinib, I would let them know, although it is a BTK inhibitor like the acalabrutinib that she was on previously, it's more selective in inhibiting its target, which is called BTK. So there are fewer off-target effects. So although the side effect profile is similar, from my understanding is the frequency of these types of side effects is lower than the covalent BTK inhibitors. As far as CAR T cell therapy, I'll say, although it is a big deal and does require you to go to a larger tertiary care center, the long-term problems and side effects are not similar to allogeneic stem cell transplantation. It's really the cytokine release syndrome and the ICANS, the neurotoxicity, that I would speak with the patient about, and some of the long-term things such as hypogammaglobulinemia and recurrent infections and cytopenias.
Thank you so much, Dr. Bachow, for those thoughts. I completely agree that there are a bunch of considerations, and I think one of the themes here is that there are a lot of patient-specific factors that go into this decision making. Dr. Patel, I was wondering if you could just highlight some of the special patient specific considerations you might keep in mind when thinking about treating a patient after venetoclax and a BTK inhibitor, when thinking about pirtobrutinib or retreatment or CAR T cell therapy.
Yeah, I would say in particular, when we think about cellular therapy, really being able to clarify to the patient some of the things that will be important to receive that therapy, being able to have a caregiver the time it takes to travel to a site that delivers a therapy if that's not close by. And as much as we can prepare patients for that need, then at the time that we are able to get the patient evaluated and seen, it will feel, I think, a lot less jarring and has the potential to go a lot more smoothly. The other I would say is that we see quite commonly in patients who are on BTK inhibitors, progression of disease is not to stop the BTK inhibitor before we've actually made a decision about which therapy we're going to sequence to, whether that's a non-covalent BTK inhibitor, venetoclax, or CAR T cell therapy. We recognize patients can have really rapid progression if we stop the therapy that they're on. And so that's another, I think, important point that everybody raised.
Thanks. Yeah, that's a great point about thinking about not stopping the BTK inhibitor, the production time, some of the logistical considerations, which I think are some of the most important in thinking about CAR T cell therapy. Dr. Bachow, I was wondering about your thoughts on bridging therapy, especially one of the things that we've highlighted throughout this presentation is that CAR T cell does have that collection and manufacturing time period. How do you think about the transition to CAR T cell therapy and thinking about bridging therapy?
So that's an interesting point you make. Whether the patient lives close to a center that specializes in CAR T cell therapy or not, I would still bridge them with something because we all know CAR T cell therapy doesn't happen overnight. The patient has to be evaluated, product has to be manufactured. There's all kinds of preparatory testing, et cetera. I certainly would bridge them.
I totally agree that bridging therapy is important, and many patients, if they are experiencing disease progression, will need some sort of bridging therapy. For patients who have not previously received pirtobrutinib, that is an option. And then thinking about the considerations that we've thought about earlier in terms of what other tools might be available, for example, venetoclax retreatment or other modalities that the patient is not resistant to. Now we're going to switch gears and talk about discontinuation of prior BTK inhibitor for toxicity. So changing the scenario a little bit, Amanda is on second line acalabrutinib and then stops treatment due to toxicity. Has a period off of therapy, but then is experiencing clinical progression. And so I'm wondering, Dr. Bachow, how you approach this situation. You know, what are your steps and what is your thought process in terms of treatment planning? And really important to this case, I think, is the type of toxicity. So thinking, does the type of toxicity matter, what the specific toxicity was, as well as how severe that toxicity was, and is it still present at the time of treatment decision planning?
Yeah, so that's an excellent question. Here's what I would do when faced with BTK inhibitor intolerance. So toxicity instead of progression. I'd probably still consider switching the patient to pirtobrutinib because I think it's an excellent drug. But what I would also do in this situation is still check for resistance mutations. And if there are none, I can consider switching the patient to a covalent BTK inhibitor, such as zanubrutinib, and save the zanubrutinib in my back pocket. It also really depends on what type of toxicity the patient was having. I really want to do everything in my power to keep the patient on the same drug and not have to take them off for toxicity if it's something that I can handle by treating it symptomatically. So if the patient had a grade 1 or grade 2 arthralgias, I'll try to treat them symptomatically with acetaminophen or a short course of corticosteroids to see if I can really keep them on the drug. If I have to, I can do a dose reduction. I usually don't like to hold the medication, but I could do a dose reduction in a patient like this. But I'd really try to do everything in my power to try to keep them on the medication. Now, if the patient has atrial fibrillation complicated by significant congestive heart failure, that's another story. I probably would not, I'd be very reluctant to try to keep the patient on the medication when they had such a huge complication and when I know I have other great alternatives.
Thank you so much, Dr. Bachow, for those thoughts. I completely agree that it's really important to evaluate the specific toxicity, the severity of it. Has it resolved? And that will really be important in determining whether switching to another BTK inhibitor seems like a reasonable option versus switching class. Dr. Patel, I was wondering if you could comment maybe on some of the cardiovascular toxicities. While I'm sure it's different for each patient, how do you approach, for example, atrial fibrillation in this setting, thinking about an alternative covalent BTK inhibitor for this patient, for example, an acalabrutinib to zanubrutinib, or switching class to something like venetoclax, or maybe considering even pirtobrutinib in this setting?
That's a great question, Dr. Thompson. I think the first thing I think about is, have we really optimized management for the specific cardiac adverse event? In the case of atrial fibrillation, is there additional medical management that can be done? Are there other contributing comorbidities that need to be managed? And really doing that in tandem with the patient's cardiologist or their primary care physician may offer us an opportunity to keep the patient on the BTK inhibitor, which is otherwise working. Otherwise, we can consider, if we've tried that and it's not still working out, we can switch to a different class, venetoclax in a patient who had previously responded and has been off venetoclax for some time, or consider non-covalent BTK inhibitor, or depending on which covalent BTK inhibitor we're using, occasionally we might think about dose reduction as well, although I would say some adverse events are not really dose dependent, and so that may not always be a possibility.
Thank you so much, Dr. Patel. I completely agree, and I think that really highlights the importance of the patient's overall care team and co-management, in this case with cardiologists. And some patients, their primary care physician is involved as well for some of these AEs, and highlights the importance of monitoring these toxicities as part of a comprehensive care team throughout therapy. So now we're going to switch gears to another case, David. He's an older patient with relapsed CLL with comorbidities, including diabetes and gastritis. He's 80 years old. He has relapsed disease and will go into his prior therapies, and his performance status is now ECOG 2. So he was initially treated with ibrutinib, had a 7-year response, but then progressed and received second-line therapy with fixed duration venetoclax and rituximab, got 2 years of venetoclax therapy based off the Murano regimen, had about 9 months of remission after stopping venetoclax, but then had relapsing disease shortly thereafter. And we're now facing what he should get for his next line of therapy. So Dr. Bachow, I was wondering, what are some treatment options that you would consider in this patient? What are some of the considerations in terms of selecting a therapy? And then how would you think about the choice between cellular therapy with CAR T-cell therapy versus a non-covalent BTK inhibitor, such as pirtobrutinib in this case?
So another interesting case, older individual with high-risk disease with a poor performance status who had a prolonged response, a remission to ibrutinib, then had progression of disease and had a short response to venetoclax-based therapy. I mean, almost could even consider it, I guess, refractory only after 9 months on the therapy. I would still check for resistance mutation since the patient did very well on ibrutinib. One consideration is to try acalabrutinib or a zanubrutinib, newer generation covalent BTK inhibitors. More likely, I would probably at this point consider pirtobrutinib. As far as referral for CAR T-cell therapy, although this patient is 80 years old and has a ECOG performance status of 2, I'm learning more and more that CAR T-cell therapy and the side effects from CAR T-cell therapy, this is not allogeneic stem cell transplantation. This is different. And although there are big side effects such as cytokine release syndrome and ICANS, et cetera, I usually don't want to be the one to say that we can't give you CAR T-cell therapy. I usually want a CAR T-cell therapy specialist to evaluate the patients. So if this patient was very motivated, I would at least refer them for a consultation to have a discussion with a physician that performs CAR T-cell therapy and let them tell this patient whether they're a candidate or not.
Thanks, Dr. Bachow, for those thoughts. Dr. Patel, I was wondering if you could highlight some of the patient-specific factors that would go into a case like this, particularly in terms of the determination about eligibility for CAR T-cell therapy, and where that might fit in for a patient like David?
Yeah, that's a great question. So, some of the things we want to think about are David's comorbidities and his performance status. We don't think about age as chronologic age alone, but biologic age. So, certainly, patients who are in their 80s, we need to be considerate of some of the more challenging toxicities of CAR T cell therapy. We also have a non-covalent BTK inhibitor like pirtobrutinib that can provide a very good durable disease control and be delivered very safely. And so I think it's important for these patients to be able to have that conversation with a cellular therapy team so that we can really individualize the recommendation. Because again, there are some patients who certainly can go through that therapy safely, but this is an area where I'd say it's really important for us to be very mindful of those comorbidities and the performance status and really try to maintain the best quality of life while treating the disease as we can. And we're fortunate to have a drug like pirtobrutinib that can help us accomplish that.
Thank you so much, Krish. So I think that, when I approach a patient like this, very similar to Doctors Bachow and Patel, I really do have a thorough evaluation with the patient. And I think this is where going to really a CAR T cell therapy center and specialist is important, because there are additional tools like geriatric assessment that really can be used to determine one's fitness for CAR T cell therapy. I think a takeaway from this case is that, pirtobrutinib is readily available. It's very well tolerated from the data we saw. And so that's certainly a very good option here. And then for select patients, doing that referral to CAR T cell therapy, if it's not available at the patient's center, is great to have the conversation to know whether that might be an option now or in the future. So to change the case a little bit, let's change David's remission interval after the completion of fixed duration venetoclax. So rather than progressing 9 months after finishing venetoclax, he now progresses 18 months after the end of treatment. So Dr. Bachow, I'm curious, how does this kind of change how you think about treatment options in this situation when one has a slightly longer remission after finishing venetoclax-based therapy?
So that's an excellent question. So 18 months after therapy versus 9 months after therapy. It probably would not change my decision making, although I would feel a little bit more comfortable about potentially retrying the venetoclax-based regimen, knowing that if the patient did not show any sign, I'd have a low threshold. I'd essentially have a low threshold to take this patient off of a venetoclax-based regimen very, very quickly if I saw any signs that the patient had any kind of venetoclax refractoriness.
Thank you so much, Dr. Bachow. I really agree that this does bring venetoclax retreatment potentially into the conversation. What that remission should be is really still an area of ongoing study. Some experts have said 2 years. The data, retrospective data on retreatment, there was a median of about 16 months between the first and second venetoclax. So I think that this is an area of ongoing study and probably some differences between providers out there. Dr. Patel, what do you kind of think about in terms of venetoclax retreatment and how you would approach this case?
Yeah, I think you said it very well, Dr. Thompson. What the really kinetics of response and then relapse are very telling. We know some patients who relapse post-venetoclax will have had, maybe subclinical clones that are progressing long before clinical progression, and that wouldn't be the patient where I think, a very short time after treatment that going back to venetoclax would be helpful. So a lot that we still have to do to really try to, as you said well, optimize the consideration of when is right and then in what patient. There may be some differences biologically as well in terms of what we see. in patients who are either IGHV mutated or unmutated as well. So lots to consider there, but I think 18 months gives us a starting point and then more data to come.
Yeah, I completely agree. I think the other thing that comes up a lot in my clinical practice when thinking about this situation, especially pirtobrutinib versus venetoclax, is the logistical consideration and again, comorbidity. So venetoclax does have the dose escalation and the ramp up with tumor lysis monitoring. Pirtobrutinib has a little bit less monitoring that during that initial time period. So I know that's something we talked to about with the patient as well. And then also, prior experience on toxicity, how the venetoclax was previously tolerated. And I know Dr. Bachow brought that up in some of his prior conversation as well. So now, as we're closing the program, I wanted to take a pause, and if you could take some time to answer some of the polling questions before we move on to some final take-home points. So when we think about relapsed CLL in 2024, this presentation has highlighted that there were really a bunch of growing options, which is excellent for our patients. I think the decision-making has become more patient-specific. And as we talked about, there's disease factors that we consider, really the prior reason for discontinuation of their prior therapy, particularly patients who've received BTK inhibitors or venetoclax. So it's really important to know, were the patients discontinuing for a side effect, or did they discontinuation for progression? And then the other things that come into play are the patient's CLL itself, their disease characteristics. Do they have high-risk genetic features, which can give some prognostic information about their disease risk and disease biology? And then the other factors that we've seen are logistical considerations in terms of the patient's availability to treatment, availability to come in for monitoring, and then proximity to centers for cellular therapy. So one option that we've seen in this double exposed and double refractory setting is pirtobrutinib as a non-covalent BTK inhibitor. I think the take home here is that pirtobrutinib has durable responses for patients who've had prior BTK inhibitor and venetoclax-based therapy, and overall is well tolerated. We talked through some of the side effects of monitoring here. I'm going to hand it over to Dr. Patel to talk about some of the take home points about CAR T-cell therapy and where that fits into the treatment for CLL patients in 2024.
Thanks, Dr. Thompson. I think in a lot of respects, the use of CAR T cells can be very complementary to the use of pirtobrutinib, and that's what we are seeing a lot in the clinic. And when I think about some of the strengths of the data we have to this point, it's that there is this potential for patients to have, once again, a fixed duration therapy even later in the course of their illness. And for those patients who achieve very deep responses, complete responses, UMRD, there appears to be very good durability for those responses and offers patients, again, time off therapy even later in the course. So we have to be careful and thoughtful about patient selection there. There are some acute toxicities of concern, and we have to be aware of management of things like cytopenias and an infection risk, and really co-manage that with patients as they return to their community oncologist. So I think CAR T-cell therapy is a very effective tool to have here, and I think complements pirtobrutinib very well.
So before we conclude, I want to highlight the CLL Society's resources. These are available at the cllsociety.org. There's a wide array of resources, both for clinicians as well as patients. Here you see the clinician resource library, and you can go to the website and look through various educational materials and handouts that are available for download and also printable. So I'll just close by saying that the other, I think, big takeaway here is that as patients progress throughout CLL, as clinicians, it's really important to really think about the patient as a whole and collaborate with other physicians That's both other physicians such as cardiologists to manage cardiac toxicities that we might come across as BTK inhibitors. Pharmacists, nurses are really important in managing patients in the clinic in terms of toxicity and looking for drug-drug interactions. And then collaboration between oncologists is also something that can be useful in the setting of CLL management, particularly as we think about collaborating between oncologists with access to CAR T-cell therapy and then specialized CAR T-cell therapy centers. So I think teamwork is really emerging as has always been important and really emerging as a really highlighting that it's even more essential as we move forward in the care of our patients. So I want to thank my co-panelists here. Dr. Patel, thank you so much for your thoughts during this presentation, your excellent presentation.
Thanks for having me, Dr. Thompson. It's been a pleasure.
And Dr. Bachow, thank you so much for your thoughts, particularly on the management of these cases. It was great to collaborate with you today on these cases.
Yes, thank you very much for having me, guys. I think this was an excellent educational session. It is a very exciting time to take care of patients with CLL. The transformation for the treatment of this disease, I think, is one of the most exciting things in the field of oncology. And I'm looking forward to seeing more and more therapies approved and better outcomes for our patients.
And with that, we'll close our program today. I want to thank the audience for their attention and thank PeerView and the CLL Society for sponsoring this program and look forward to your participation in future programs.